Let me ask you something that your doctor has probably never asked you. What if the blood pressure number you have been told to chase your entire life was never actually designed for your body, your age, your biology, or your health? What if that sacred number, 120/80, the one plastered on clinic walls, repeated at every checkup, drilled into your brain since you were a teenager, was never truly based on what is ideal for you as an individual, but instead became a universal target for reasons that have very little to do with your personal well-being and a whole lot to do with something far more uncomfortable to talk about? I know that sounds alarming. I know it might even sound like a conspiracy theory. But stay with me, because what I am about to share with you is not fringe science. It is not misinformation. It is a growing conversation happening among physicians, cardiologists, and researchers who are starting to ask the exact same question out loud. And the answer is shaking the foundations of how we think about blood pressure entirely. Because here is the truth that most people sitting in a doctor's waiting room will never hear. Blood pressure is not a one-size-fits-all number. It never was. And treating it like one may be causing real, measurable harm to millions of people around the world right now. Let's start at the beginning. Blood pressure is made up of two numbers. The top number is called systolic pressure, and it represents the peak force your heart exerts when it contracts and pushes blood through your arteries. The bottom number is called diastolic pressure, and it represents the resting pressure in your arteries between heartbeats, the quiet moment when your heart is filling back up and preparing for the next contraction. Together, these two numbers give us a window into how hard your cardiovascular system is working. And for decades, the gold standard that the entire medical world aligned around was 120/80. If you were at or below that, you were considered fine. If you drifted above it, warning bells would go off, conversations about medication would begin, and the system would start pulling you toward pharmacological management. But here's where it starts to unravel. The human body is not a factory standard machine. Two people can walk into the same clinic with the same blood pressure reading and be in completely different states of health. A 72-year-old man whose blood pressure runs at 135/85 may be in perfectly natural physiological balance for his age, his arterial structure, and his kidney function. Meanwhile, a 38-year-old woman with that same reading may be showing early warning signs of metabolic dysfunction that genuinely needs attention. The number is identical. The meaning is completely different. And yet, for years, we have treated both of these people the same way. And that is where the real danger begins. Here is something that your body does entirely on its own as you age, something that is not a disease, not a failure, not a crisis. It is biology. As we grow older, particularly after the age of 60 and increasingly after 65, the walls of our blood vessels naturally begin to stiffen. The elasticity that allowed them to expand and contract with every heartbeat gradually decreases. This is a documented, well-understood physiological process. And because your vessels are less pliable, your heart has to generate slightly more pressure to push blood through them efficiently to reach your organs, your brain, your muscles, and your extremities. So a slightly elevated blood pressure reading in an older person is not always a red flag. In many cases, it is the body doing exactly what it was designed to do. It is compensating. It is adapting. It is keeping you functional. And when we aggressively intervene with medication to force that number back down to the level of a 35-year-old, we are not restoring the body to health. We are potentially disrupting a finely tuned biological compensation mechanism that was protecting the person in the first place. The consequences of that disruption are not abstract. They are real and they are serious. Older patients who are over-medicated for blood pressure often experience chronic dizziness, persistent fatigue, brain fog, a feeling of weakness that they cannot explain, and their doctor does not connect to their blood pressure medication. And in the most dangerous cases, they fall. They fall because their blood pressure drops too low when they stand up quickly, a condition called orthostatic hypotension. And in elderly populations, a fall is not just an inconvenience. A fall can be the beginning of a catastrophic chain of events. A broken hip, a surgery, a complication. And statistics tell us that hip fractures in the elderly carry a 1-year mortality rate that would shock most people. So, when we talk about the risks of untreated high blood pressure, we must also talk with equal honesty about the risks of overtreated blood pressure. And that conversation is still far too rare in mainstream medicine. Now let's talk about the other end of this story, the part that applies to younger people, the part that is perhaps the most overlooked and the most actionable piece of information I can share with you today. Because if you are under the age of 50 and your blood pressure is creeping upward, the question your doctor should be asking, and very often does not ask, is not, which medication should we start? But rather, why is this happening in the first place? And the answer, in the overwhelming majority of cases, comes back to a single root cause: insulin resistance. Insulin resistance is a metabolic condition where your body's cells stop responding efficiently to insulin, the hormone your pancreas produces to help move glucose from your bloodstream into your cells for energy. When this system breaks down, your insulin levels stay chronically elevated, and that excess insulin triggers a cascade of effects throughout your entire body that directly and powerfully drives blood pressure upward. It impairs the ability of your blood vessels to dilate and relax, a process called vasodilation. It activates your sympathetic nervous system, the fight-or-flight system, keeping your body in a state of low-grade physiological stress around the clock. It causes your kidneys to retain sodium instead of excreting it, which increases blood volume and therefore pressure. It damages the inner lining of your blood vessels, the endothelium, reducing their flexibility and function. And it activates a hormonal system called the renin-angiotensin-aldosterone system, which further constricts your blood vessels and raises your blood pressure even more. Every single one of these mechanisms is driven by insulin resistance. And insulin resistance itself is driven largely by lifestyle, specifically by a diet that is chronically high in ultra-processed foods, refined carbohydrates, added sugars, and seed oils, combined with physical inactivity, chronic sleep deprivation, and high ongoing stress. We are living in the middle of a global insulin resistance epidemic, and the medical establishment's primary response to the blood pressure consequences of that epidemic has been to write more prescriptions, more medications, more pills, not fewer ultra-processed foods, not more education about metabolic health, more pills. And that, for a growing number of physicians and researchers, is the uncomfortable truth that is impossible to ignore. So what should you actually do? What does a genuinely informed approach to blood pressure management look like in practice? The first thing, and this is critical, is to stop relying exclusively on blood pressure readings taken in a clinical setting. White coat hypertension is a real, well-documented phenomenon where blood pressure spikes simply because a person is in a medical environment feeling anxious or stressed. If your only blood pressure data comes from a nurse measuring it once before your doctor walks in, you are working with incomplete and potentially misleading information. Get a validated home blood pressure monitor. They are affordable, widely available, and far more useful than a single clinic reading. Then measure your blood pressure consistently, morning, afternoon, and evening, over a period of at least 2 to 3 weeks. Record every reading. Bring that log to your next appointment. Compare your home device to the clinic's machine to make sure they are calibrated similarly. This gives you and your doctor a real picture of what your blood pressure is actually doing throughout the day, not a snapshot distorted by situational stress. The second thing is to take metabolic health seriously as a root cause intervention. If you are younger and your blood pressure is elevated, work with a doctor who will actually test your metabolic markers: fasting glucose, fasting insulin, HbA1c, and the HOMA-IR score, which is a calculated measure of insulin resistance. If your numbers reveal insulin resistance, which they very likely will, then addressing that through dietary changes, significantly reducing refined carbohydrates, added sugars, and ultra-processed foods while increasing whole foods, fiber, protein, and healthy fats, along with regular physical activity, improved sleep and stress management, can produce dramatic reductions in blood pressure. Not theoretical reductions, real, measurable, clinical reductions that allow many people to reduce or entirely eliminate their blood pressure medication under proper medical supervision. This is not wishful thinking. This is what happens when we treat the cause instead of suppressing the symptom. The third thing is to have an honest conversation with your doctor about whether your current medication regimen is appropriate for your specific age, physiology, and daily blood pressure readings. If you are older and your home readings are consistently showing a systolic below 115 or 120, ask your doctor directly whether there is room to reduce your medication dose. Ask about the risks of low blood pressure for someone your age. Ask about orthostatic hypotension. Ask whether the target you are both chasing was based on research that actually included people your age and your health profile, because in many landmark blood pressure studies, the populations studied were not representative of the elderly patients now being treated based on those same guidelines. You are not being difficult by asking these questions. You are being an informed participant in your own healthcare. And that is not just your right, it is arguably your responsibility, because no one has more at stake in the outcome of these decisions than you do. The medical system, for all of its extraordinary capabilities, is not a monolith of purely selfless wisdom. It is influenced by funding, by pharmaceutical relationships, by guideline committees whose members have financial ties to drug manufacturers, and by institutional inertia that makes changing established protocols slow and painful, even when the evidence demands it. That does not mean you should distrust every doctor or reject every medication. It means you should be engaged, informed, curious, and willing to ask hard questions, because the quality of your health decisions will be determined not just by the advice you receive, but by how actively and thoughtfully you participate in the conversation. Your blood pressure is one number among thousands of data points that make up the complex, dynamic, living system that is you. Treat it that way. Understand what drives it, address the root causes where possible, monitor it intelligently, and never let a single clinic reading written hastily in a chart become the whole story of your cardiovascular health. You deserve better than that, and the science increasingly agrees.